I'm honored to be here. Thank you so much for the invitation and the ability to speak to something which is very important to me, and I think to everyone here. I will say that my focus is more on the financial impact, but it's a very important focus when we talk about the cost of medical care, of course. And when we're talking about epilepsy, it's one of the scariest conditions for many families to consider their child going through. So I think it's very important to really consider all of these things when we think about how we can be doing better in the future. If I can take 1 minute for a quick aside, I just want to say I really appreciate the prior speaker's use of a Billy Joel song, and that specific one. My first date with my wife ended with karaoke, which was very brave for a first date. But I knew my go-to song, which is REM's It's the End of the World as We Know It, and given that we're talking about the climatopathy, I think that's a fair statement, or concern. She ended up having a number of her friends that we ran into because she was from Miami and I was not. And so they all joined her as they did Billy Joel's It's the End of the World as You Know It. Billy Joel's We Didn't Start the Fire. And it's really hard song to do by karaoke because there's not a through line. It's just all headlines and headlines and headlines. So I really appreciate whenever it's up there. It just makes me think of that. So thank you. All right. I am the Associate Medical Director for the Epilepsy Program at the Nicklaus Children's Hospital. We are a Level 4 Epilepsy Center. And I'm also the Director of the Ion Channel Epilepsy Clinic and the Co-Director of the Tuberous Sclerosis Clinic. And I'm here to talk about this because I think it's important to understand that epilepsy care is unfortunately expensive care, but when done well and done right, that is important to consider, may end up meaning a great deal for the families and for the patients to improve things in the long run. I will be discussing some off-label use of medications, really research stuff and devices. As well as I've had a number of speakerships and consultations and things like that. This is a brief outline of what we're going to be going over, and I always start my talks with a little bit of definition because I'm not sure where everyone is in the room about the understanding of what epilepsy is and what drug-related epilepsy is. And also because the data on this is highly dependent on what the definition was at the time, and the definitions do actually change. In 2014, the definition of epilepsy was redefined as a disease of the brain defined by at least 2 unprovoked or reflex seizures occurring more than 24 hours apart, or 1 unprovoked reflex seizure and a likelihood of another greater than 60% over the next 2 years, or the diagnosis of an epilepsy syndrome. And for many people, the question is, well, what's an epilepsy syndrome? And those of you who have dealt with pediatric patients or adult patients, one of the common ones is childhood absence epilepsy, where it's kind of a recognizable type of epilepsy. It occurs at a certain age, it has a certain type of seizure, it has typical EEG features. You can kind of get an understanding of what's going on with that child based off of that. And not every epilepsy patient has an identifiable epilepsy syndrome. But if they have something by the history and by the features that sound like a recognizable syndrome, such as juvenile myoclonic epilepsy, you might be able to diagnose that after the first seizure, even though they haven't had more. Drug-resistant epilepsy has been pretty well established since 2010 to be this idea of failing to get complete seizure control after the utilization of 2 appropriately chosen and appropriately tolerated anti-seizure medications. But this wasn't always the case, and sometimes that feels a little incomplete to some people. It's like, well, if I even have 1 breakthrough seizure, is that enough? And I posit to you that it is. Prior to that definition, people would say, well, how soon can you really diagnose intractable epilepsy, drug-resistant epilepsy? And if you took a look at it and said, well, I'm going to compare just the idea of failing to have complete control with 2 appropriately chosen medications and well tolerated versus I'm going to put a threshold on how many seizures they're having. And some people were literally saying that they needed to have an average of a seizure a month over an 18-month period despite treatment. That's a lot of seizures, particularly if they're convulsive seizures. And if you needed to have that, well then of course, in the top graph on the right, you're really delaying how soon you can identify whether or not that patient has a drug-refractory epilepsy. If you, on the other hand, are more liberal and utilizing the definition that has essentially now been accepted, where it's 2 or more medications, either in monotherapy or combined, have failed to get complete seizure freedom, that identification of drug refractory epilepsy can be done much sooner. And that's very important for these patients. And it is different dependent on the type of epilepsy that occurs. There are some epilepsies that are more likely to be drug refractory and where you may find out sooner. But all in all, we want to make this identification quickly in order to be sure that we're helping the patients quickly. It's like the stroke doctors mentioned, time is brain. And the amount of seizures that a child is having and the amount of time we're waiting to really get them into the right evaluation and the right care is really potentially limiting their long-term potential. It should be noted that even now, these definitions continue to be reworked and reconsidered. So the International League Against Epilepsy and the American Epilepsy Society have a joint task force, translational task force, that's sort of proposing revisiting this to consider how does the pathophysiology and the genetic features and the underlying cause of the patient's epilepsy really help us define the ability for us to say that they have drug refractory epilepsy. It should also be noted that that definition of drug resistant epilepsy being for 2 or more medications, again, is saying that these are appropriately chosen and they're not the wrong type of medicine for this type of epilepsy, which is relevant particularly in some of the genetic cases. Also that we're not talking about patients who have not taken their medication appropriately for one reason or another, be it non-adherence, be it inability to afford medications, be it intolerable side effects. That's a different consideration where we need to be adjusting our care as well. When you take a look at the incidence and prevalence of drug-resistant epilepsy, again, this varies across study and partly related to that definitional aspect and partly related to methodological considerations for each study, but it's generally considered that around 32-33% of patients with epilepsy will have drug-refractory epilepsy, so that they will be failing to get complete seizure control after 2 adequately tried medications. And again, depending on the study, the risk factors in children include age less than 12 months. That doesn't come out in every study. Developmental delay at diagnosis. If they already have ongoing developmental delay, that suggests that there is something different about their epilepsy potentially. An abnormality on neuroimaging increases the likelihood of the drug refractory epilepsy, as does focal slowing on EEG. And there's an error on the slide because I said for drug-related epilepsy, 6 in something, met criteria by 1 year, that's about 6 in 10, met criteria by 1 year from diagnosis of epilepsy. So again, even waiting that 18 months of averaging 1 seizure per year is potentially adding another 6 months to that diagnosis time and making it seem like maybe their epilepsy isn't as severe when they need that earlier intervention if possible. The impact on the individual and the community is potentially massive. So when we think about the direct and indirect healthcare utilization and costs, the costs related to epilepsy account for approximately half of their overall healthcare costs for these patients, including medications, including ER visits, doctor's visits, inpatient administrations, missed days at school, missed days at work. The epilepsy really seems to overwhelm it. And that's when I'm saying epilepsy, but it doubles again when you start talking about drug-resistant epilepsy. So this is massively important to people's day-to-day lives and also to society in general when we're talking about who's actually paying for the care. How much of that is on the patient, how much of that is on insurance, how much of that is on government. The costs are predicted to be 1.5 to 2 times higher than control healthy patients or patients just without epilepsy at age 30. And we can really see this in these 3 populations for Lennox-Gastaut syndrome, Dravet syndrome, and tuberous sclerosis. Tuberous sclerosis syndrome can cause many different types of epilepsy, including the Lennox-Gastaut syndrome, which is all the way on the right. But essentially, if you're looking at these 3 populations, these are some of the worst types of epilepsy as far as the ability to gain long-term seizure control and some of the most challenging patients that we have. Lennox-Gastaut syndrome can happen for many, many reasons, so it may not always be fair to lump as many patients together because we might be able to actually separate some out based off of etiology. But in general, these patients are the ones that you would look at and say, oh, how are they doing? They're going to be the ones that are actually having probably the most burden on themselves and upon society for the cost. When we think about the burden of cost, and that, though it's not all just about the financial, it's also about how does their life go. So when they estimated, this is adapted from an article that was looking at the socioeconomic impact on patients at age 30. The original table was very small, and so I wanted to try and hopefully highlight it so you'd be able to see it a little better. I'm just going to go through a few key points, but the idea here is how are they doing at age 30 for these patients who started having epilepsy as children. They separated them out between onset between 0 and 5 years and between 6 and 20 years, and they compared them to age-matched controls. And if we just take a look first at their estimated income, they have an estimated income 10 to 15% lower than their healthy age-matched controls. So that is exceedingly limiting towards their long-term prosperity. But on top of that is when you think about their highest educational attainment, where the patients who had epilepsy had a much higher likelihood of only getting as far as primary education. The secondary education and vocational education doesn't actually look that different, but take a look also at the college levels. A lot of the patients were limited in how far they could go, and those that weren't limited necessarily were at least able maybe to get through the secondary and or the vocational school, but they didn't as often get to college level education. So this is, again, leading to a limitation in potentially how far they are able to go in their career. In their career is also important to consider. When you take a look at the unemployed rate, the number of patients in the epilepsy groups versus the control groups doesn't look that different if you're just looking at that number unemployed. But there's a difference going on there in the number that says employed, right? The control groups had 82% and 85% employment, but the patient groups had 60%. Why is that? Well, that's because the patients ended up, instead of being listed as unemployed, being on disability. And there was a much higher group of this patient population in the epilepsy group that's on disability rather than, again, the controls. And when we're also talking about this, here I've been talking about their careers and about their income potential, but let's also talk about family life, right? So patients with epilepsy have a much higher likelihood of not going on to get married. This is not to say that they shouldn't. Of course, we want everyone to be living their full life, their full potential, but unfortunately, there's a stigma associated to epilepsy. And we want to try and combat that. We want everyone to be able to go forward on that. There used to be, and may still be in many places, some laws that actually said that people with epilepsy were not allowed to get married, but I think that those are typically not enforced, at least not that I've looked into anymore. So this is a major impact on the long-term life for these patients. And again, on their caregivers, on their families, on their workplaces, on the people around them. And we want to be sure that we can do something for all of these people. So the first thing we need to do is make sure we're making the right diagnosis. Make sure we're really helping people understand what's going into all this and why is that. And often, we'll be up here, we'll be talking about, well, here's the testing that we do, here's the testing that we do, here's the testing that we do. And I bet everyone's going to expect me to be talking about how wonderful an EEG is. An EEG is like the EKG of the brain, right? It's a brain wave test. We're looking at the brain waves. They're called that because they go up and down and they look like waves, right? Like waves on an ocean. And our brain has them all the time. And the EEG is usually the first test that is done, unless you're talking about potentially a CT in the emergency room. But seeing a neurologist, they're often able to get an EEG pretty quickly. So that sounds like, okay, that's going to be the first thing we're going to do. Actually, no. There's limitations to the EEG, and I'm going to posit to you that the most important thing we do is the thing everyone here does as a provider or as a caregiver. It's taking a history and understanding what is going on with the patient, because there are actually limitations to the EEG. Just like every other test, there's false positives and false negatives. It is possible to have an abnormal EEG and not have epilepsy. For children with low suspicion of seizures and epilepsy, the EEG can really be of limited use. And this was looked at where they looked at just the order for the EEG, looking at who ordered it and why they ordered it. And based off of just looking at that, they were able to say that 90% of the time, we think this is going to be a normal EEG. They were right. All right? So if you're getting a test that you think it's going to be normal, why are you getting that test? When it came down to, we think this patient has epilepsy, a number of patients with epilepsy can still have a normal EEG in between their seizures. So you can have a false negative there. But importantly, how accurate were the doctors in determining in advance what type of abnormality would be on that EEG? Well, in a specific epilepsy syndrome, the self-limited epilepsy with central temporal spikes, or what used to be called the Rolandic epilepsy, they were quite predictable that what type of abnormality would be. But for almost any other type of epilepsy, the ability to predict what the abnormality would be on EEG was actually kind of poor. It was certainly higher than chance, but it wasn't 90%. It was more like 40, 50%. One of the ways that we get around the fact that EEG can sometimes be normal and a patient has epilepsy is by getting serial EEGs. And you get a few of them, or maybe you get a prolonged EEG, like an ambulatory or an overnight EEG. And the more time you have, the more likely you are to find abnormalities. But there's still a problem. If you take a look at the two graphs, these two graphs have different numbers, different denominators. They're not the same patient population. They're just looking at ratios, but they're telling an important story because the blue graph is patients who had an unprovoked seizure, but went on serial EEGs, 1, 2, 3, to end up having an epileptiform abnormality, a spike or a sharp that would cue you into think that those patients might have seizures. But those the blue line, they did not go on to have epilepsy. This is a long-term evaluation of patients. This is retrospective analysis, but with about 30 or 40 years worth of population-based data. They did not go on to develop epilepsy, but a high percentage of them on serial EEG still had an abnormality on that EEG. So it has to be taken into account the history. Along with that, there are factors that can affect whether you're likely to have an abnormality on EEG. And one of the most common ones is patients who have a neurodevelopmental disability, such as autism. Patients with autism are at higher rate of epilepsy. Patients with autism are also at a higher rate of abnormalities on their EEG, even if they do not have epilepsy. So frequently, there's this idea that a patient comes in for staring spells. Maybe they have absence seizures, or maybe they have focal altered awareness seizures, and we're going to get an EEG and try and get the answer. But the problem is that the patient may have an abnormality on the EEG, and that staring spell might actually still be behavioral. It's very easy to say, there's spells and there's a spike, so it must be seizures. I'm going to put a patient on medication, but they may not actually require that medication. And if you take a look at this graph here, the gray bars are patients who had autism and ended up having a normal EEG, but the red is patients who had autism and had abnormalities on their EEG, and again, did not at that time have seizures. Patients with autism, as I mentioned, do have higher rates of epilepsy, and so it may be that in the future, in the long run, they may go on to develop it. That does not mean they have active epilepsy now. We also know that children of patients, basically your first-degree relatives, are more likely to have abnormalities on the EEG too. And so that's possible to essentially be an inherited pattern. So if you have epilepsy, it might be that your sibling or that your parent, if they were to get an EEG, might have an abnormality on that EEG, even if they never have epilepsy. So it's not a good idea if parents come to you and say, well, Timmy has seizures, should we get Johnny an EEG? The answer is no, not until he has symptoms, not until we can really account for what's going on there. And what's often not talked about, although I was very pleased with this issue of the Journal of Clinical Neurophysiology, is, as I mentioned, it's a test, and tests are imperfect, and part of the reason they're imperfect is the raters. And EEG rating actually often has a kind of poor inter-rater reliability, and there's a number of things that can occur that can look spiky and can look pathological, which might actually be normal variants, or might actually be related to technical factors with the electrodes or with the cables. And so the Journal of Clinical Neurophysiology in July of 2019 had an issue where the first 6 or 7 articles were all dedicated to ways that the EEG can be overinterpreted. And so that needs to be considered. But assuming that you have taken a good history and that you believe this patient to have epilepsy, an EEG is an amazing test. It is a really, really helpful test to understand what is going on with those patients, assuming you've done those things. And then on top of that, the next important thing is education. And education of the parents and the family is very important, but here I'm talking about education of the fellows and of the residents and of the people who are taking care of them about how to take the data from the EEG and understand what's going on with the patient. So this is a simple classification system that was tested by reviewing it with the neurology residents of looking at essentially 2 features about a routine EEG where a patient did not have a seizure in that EEG. And the 2 features were the background activity and the types of spikes. So the background activity, we all have brains that are active all the time. It makes those waves going up and down, right? I might not be as active right now because I'm speaking. No, actually, I'm very active. But we all have that, and there should be a certain organization to it. It should look a certain way depending on your age and your developmental status. And the above the line in here, the three pi figures that are above the line all have sort of a normal background, and below the line all have some amount of slowing or disruption of the background, be it slowing throughout or be it in just one focal area. And then on top of that, in the pink, there's no actual spikes for those patients. They can still have epilepsy. As I've mentioned, a person with epilepsy could have a normal interictal EEG. The green is where they have focal spikes, and the blue is where they have generalized spikes. So if you can see this, this was a normal looking EEG. Here's a couple spikes. These are the same spikes. This is the temporal chain, and then this is next to it, the parasagittal chain. And then these are diffuse spikes. But the idea here is that these spikes kind of look predictable. They kind of look the same from group to group to group, from patient to patient to patient. They're kind of stereotyped in nature. And that together puts these all in sort of these idiopathic or epilepsies, where often actually our outcomes are quite good, but you still have a rate of drug-resistant epilepsies below, within them as well. Still can be in the 20 to 30% range. Versus down here, again, we have some amount of slowing, be it diffuse, which is going to be in these two over here, and also these very non-stereotype looking spikes, very irregular appearing. And over here, this sort of continuous slowing in one area. This is actually the neighboring electrode, whereas the other side looks normal. So we've got focal slowing, and this is more suggestive of a structural epilepsy. Utilizing a structure like this, combined with understanding the age of onset for the different named epilepsy syndromes that we see in childhood, led to a significant improvement in the fellow's ability to identify the type of epilepsy that a patient had, just from a 30-minute EEG and a very brief history. As a result of that, we are able already to say, okay, what's the likelihood of a patient being well treated quickly versus taking some time, versus needing one medicine versus needing two, because again, above that line was more likely to be medication responsive. Below that line was less likely. There is a rate, again, that can still be as high as 20-30%, but these ones are almost universally very difficult to control. On top of that, there is a problem. A person can start up here and end up down here, right? So it is a matter of epilepsy being an evolution. But if you can, with reasonable confidence, identify the likely type of epilepsy, you can also then utilize some rational reasons about which medication I'm going to use, right? Because the different types of epilepsy may respond differently to different medications. You wouldn't want to use a medicine like carbamazepine for absence epilepsy. You're likely to make their absence seizures worse. So, but you would want to use it in the scenario of this category here or this category here, which is where we have that central temporal epilepsy that I had mentioned earlier. Similarly, you're more often going to use things like ketogenic diet on these very difficult to control patients down here, or vigabatrin where we have infantile spasms in this category, or steroids in that category. So the EEG and the education can be a cheap way to really make sure we are providing high quality, individualized care for these patients. Very simple to get started, right? And also, if you know something about those groups above that I had mentioned, if they do fit the pattern of some of those epilepsy syndromes, some of those are unlikely to find something helpful on the MRI, like childhood absence epilepsy, like Rolandic epilepsy. So ultimately, you may not need to MRI some of those patients, but if you need to MRI the patients, if you need to really understand it because the patients don't quite fit into one of the categories, or they fit into a category where they're at higher rate of having something on the imaging, the MRI is usually the next step. But then the question comes, well, what about metabolic testing? What about autoimmune testing? What about genetic testing? Well, this gets expensive as you start adding it all up. But what's been identified is that genetic testing, which has become much, much more available, actually helps decrease the cost when it's brought in earlier. All right, and there are certain scenarios where you want it very, very early. And that can end up leading us to not need to do certain unnecessary testings. But on top of that, it frequently leads to changes in what our management is and how we consider which medications we're going to use, whether or not we would consider surgery in some cases. and that can help improve the outcomes for these patients. The treatment has been growing and changing. This is well before there was such a thing as approvals. This is a potassium bromide back in the 1850s. And believe it or not, there are still some patients who are getting this because they're very difficult to control epilepsies. And then here in 1912, I believe, was phenobarbital. And then you can see how the number of medications has just ballooned and ballooned and ballooned in recent years. And unfortunately, despite all this, 30% of patients, 30 to 33% of patients are still having uncontrolled epilepsy. It's not that the medication is doing a better job controlling the epilepsy, although frequently with the newer medicines we may find that we have lower side effect profiles, which can be good. The way that we choose our medications can sometimes seem kind of outdated, because I've already said we're going to go based off of syndromic diagnosis. So here we have the idea of we've got a seizure type and we have an epilepsy syndrome. So focal onset seizures, we have generalized tonic-clonic seizures, absence seizures, and we go from a medication based off of that. We're just using a diagnosis to start. And it is a great start. And for many patients, for that first line of patients, that may be very helpful. But the problem becomes, again, that not everyone with the same syndrome has the same thing. So this is a gene, the CHD2 related epilepsies are showing here the various different types of epilepsy that patients with gene mutations in that condition has. And the CHD2 doesn't have a specific, here's what you're going to utilize to treat necessarily. But again, if you assume that all these patients are having epilepsy for the same reason, it's not fair to state that all the patients with Lennox-Gastaut syndrome in this population may respond to the same things that people who have Lennox-Gastaut for other genetic or structural reasons would be. So this is helpful, but not the end-all be-all. It's sort of our older model. As we get more genetic diagnosis, this is changing things. Single gene diagnosis can significantly direct the care. So the most commonly talked about, I think, right now is the SCN1A related Dravet syndrome. This is not the most common single gene epilepsy, but it's the most commonly spoken about at the moment, where we have expert opinion guidelines about what medication to utilize. It's a mutation in the sodium channel gene, in one of the sodium channel genes rather, SCN1A, initially, some person might have thought, oh, so I'll use sodium channel blockers, but what it actually is causing is a malfunction, a decreased function of the sodium channel gene, so you add a blocker and you cause a problem. And that's why we avoid carbamazepine, oxcarbazepine, lamotrigine, and phenytoin in this range, in this condition, versus we have guidance to utilize valproate, fenfluramine, stiripentol, clobazam, cannabidiol, ketogenic diet, all in sort of a staged manner here, based off of the expert opinion. CDKL5 is another genetic epilepsy. This causes epilepsy with microcephaly that is progressive, developmental delay, very difficult to control epilepsy. And here they've utilized a neurosteroid, which is also a GABA receptor allosteric modifier, and found improvement compared to placebo. KCNT1 is a potassium channel gene that causes an early infantile epilepsy with migrating focal seizures and can be very difficult to control. And what some people have tried is quinidine. And quinidine seems to help in some cases, but the problem is the dose that you need to get to for quinidine is quite high and can cause cardiac problems. And it can be more difficult because these early infants are often on phenobarbital, and there's an interaction from the phenobarbital that lowers the quinidine level. So it can be very hard to get where you need to be. But utilizing some analysis of what's actually going on at the channel level using microelectrodes in the lab, they were able to identify that certain other molecules, certain other things already available might also be helpful. So they were able to actually normalize the function by adding in fluoxetine for this in the lab model. What did that lead to? Of course, some people tried off-label fluoxetine. And here we have a patient who has an abnormal EEG over here, who afterwards had normalization of their EEG and a significant decrease of their seizures as well as improvement in their behavior despite having tried topiramate, diazepam, carbamazepine, clobazam, nitrazepam, oxcarbazepine, acetazolamide, clonazepam, again oxcarbazepine, and lamotrigine. The fluoxetine is what made the significant difference for this patient. CHRNA4 and autosomal dominant sleep-related hypermotor epilepsy. It should be noted it's not just CHRNA4. There's a couple other of these CHRNAs, but these are a nicotinic acetylcholine receptor. Nicotine is a modifier of the function of this protein. And this is a chart of some patients because someone had noticed that some of these patients with sleep-related epilepsy, when they smoke, actually seem to have fewer seizures. So they actually tested it. And they gave patients some version of nicotine. The purple box at the top are actually pediatric patients. It's a 9-year-old and a 15-year-old. They did not have them smoke. They gave them nicotine patches. This was not limited, however, only to nicotine patches. I think some people here even had some other mechanisms of receiving it. Oops, I went too far. And I've highlighted with these purple brackets patients who had good and very good responses. They didn't do anything else to get this. They added nicotine, and these patients had significant improvement in their seizures. So this goes on and on. TSC1 and TSC2 causing some severe forms of epilepsy, but if you capture TSC very early in life before, say, they develop infantile spasms, then getting an EEG, seeing that there's an abnormality, and starting vigabatrin may prevent infantile spasms, although not necessarily other types of epilepsy. So prevention can be massive. SLC2A1 is a genetic condition where you don't move sugar from your blood to your brain. So it doesn't matter the medicines you give for these patients, you need to correct that somehow. What we do is we put them on the ketogenic diet. And this condition can cause any variety of epilepsy, movement disorder, some microcephaly, and some intellectual disability. It can have only some of those. So it may not always be an epilepsy condition, and correcting it with the ketogenic diet can help improve not the microcephaly, but the cognitive outcome and certainly the seizure outcome for these patients. And it's often the only thing that works. So again, we may be able, by identifying these patients genetically, to figure out how the patients can be better treated, either with the known anti-seizure medicines we have, or repurposing older medicines that are already approved for something else if we can learn enough about the condition. But on top of that, we want to be able to get to the root cause, because none of these are addressing the root cause. So when we take a look at some of the research that's coming forward into genetics, we're trying to see how we can get the body to correct some of that. So this is an approach called the TANGO approach. It's utilizing an antisense oligonucleotide. The gene is turned into an mRNA, and then the mRNA, of course, is coded into a protein. The mRNA for the SCN1A has a part of it that it actually is going to end up being spliced into 2 copies, but one of those copies has a degradation signal on it. And so what we provide in this research study is an ASO, an antisense oligonucleotide, that kind of binds to that degradation signal, and it tells it to ignore it. So as a result, you produce more of the normal type protein. You'll also end up producing more of the abnormal type protein, but it won't end up mattering because it doesn't do anything. So it just goes away and gets degraded. And the goal here from this trial is to help stop seizures and try and get patients to have better long-term development. On the other hand, the benefit here is that we're not actually putting in something into their genetic code, right? But it's going to need continuous, intermittent dosing in order to have long-term effect. Versus there's another trial that's being planned, and there's a couple sites in an early version of it, where we're actually providing a sort of a circular episome that again won't be incorporated into the person's actual chromosomes. So we're not splitting anything, we're not causing that sort of a problem, but it's going to lead to a signal that will allow for increased transcription of the normal protein. These are ongoing studies, as I've mentioned. And this is not going to work for everyone because ultimately some patients have more active rather than less active, so you wouldn't want to be having them have more protein created. But as we understand the conditions and as we understand the genetics, more and more of these individualized therapies may come out. And so you need to have an approach to identify patients so you can get them into the observational studies, so we can understand the conditions, so we can have some historical comparisons, and so you can get them into the actual interventional studies. And our approach to that has been having this multidisciplinary clinic where it's myself, the medical geneticist, the neuropsychologist, and also in our clinic is frequently the ketogenic diet provider, because a lot of these patients end up on the ketogenic diet. And that way we can be thinking about what are some of the things we could be doing, which may not be necessarily standard, but maybe new avenues for the patients, and who can we get them to if we aren't the people who have that trial Or can we become a site for that trial? Because we want to be sure that we're really making these patients get the opportunities that would be essentially denied to them otherwise. Switching gears, in 1984, the Nicklaus Children's Hospital, at the time, I'm not sure if at the time it was considered the Variety Children's Hospital. It's gone through a couple name changes. It was the Variety Children's Hospital, then it was the Miami Children's Hospital. Now it's the Nicklaus Children's Hospital. But in 1984, the hospital performed our first surgery for the treatment of intractable pediatric epilepsy. And we've had a thriving program ever since then. And it's important when you have such a program that you contribute to and advance the knowledge with that. And there is a long history of publication based off of our experiences for how do you select a patient, how do you characterize their epilepsy, how do you analyze the EEG, what do you do when that MRI didn't have abnormalities on it, how do we preserve normal function in some of these patients when we can, what is the use of new techniques like fMRI and source analysis to help guide us in some of these things. And of course, a lot of that has been from our specific experience, but a lot of it has also been in collaboration with other centers, because this is something that is ongoing, and the more that we do, the more we know that we need to be a community about it. And so the end result is that we've done at our hospital over 1,600 epilepsy surgeries in children. And over the past 30 years, we have transitioned our philosophy about how we do that. The rates of large multi-lobar or hemispheric surgeries has been decreasing. It's not zero, and it won't be, and I'll explain why, but it's been decreasing while more limited resective, disconnective procedures have been going. So what am I saying when I'm talking about that? If we think about the brain and what we can do to it to try and stop seizures, we can think about it as far as the larger procedures where we have a large treatment volume at the bottom, and that's where we are performing something like, say, a hemispherectomy, where we disconnect. It's no longer an anatomic usually, but we disconnect a hemisphere in order to try and stop those seizures, versus a very, very small thing, like just taking a small piece of cortex or even a laser. And you can assume, therefore, that if we've taken a large volume, we are not preserving as much. We're certainly preserving the other side, but if we're only taking a very small out, well, they've got a lot more brain that we've preserved there, so we try to preserve function very well. On the other hand, if we're targeting seizure reduction because we don't believe that the patient currently classifies as something that we could really target seizure freedom, well, then we have some neuromodulation techniques. I put corpus callosotomy over here. This is a procedure where we just disconnect the two hemispheres from each other, but we don't actually remove one of the hemispheres. This may be targeting seizure freedom for drop seizures, but often those patients have other types of seizures, and they may get better, but they usually don't go away. So there are some scenarios where you would consider that this is targeting seizure freedom if you're saying specific seizure type, but not necessarily all seizures. This is a scenario where you might consider, and where we did perform, a functional hemispherectomy. This is a patient who, it's hard to tell now, was born with a very asymmetric brain, where one side of the brain was very large and dysplastic. This is called hemimegalencephaly, and they're born with it, and they can have very severe epilepsy from very early on in life. When that happens, if you can disconnect that malformed hemisphere, you may be able to stop all of the seizures and therefore allow them to have better function on the preserved hemisphere. Because that preserved hemisphere, while it's still connected, is being interrupted all the time. And there's good data that earlier intervention of these leads to better long-term cognitive outcomes. Now, because of the abnormalities in the anatomy, it can sometimes be difficult to be sure that you have a complete disconnection. But this is really the best form of treatment in this scenario and certain other epilepsy conditions. As opposed to the idea of a more focal resection, this is a patient with tuberous sclerosis. Now, this patient has multiple cortical tubers in different areas. But when we took a look at the type of seizures that the child was having, the way that they manifested, and how the EEG showed where the abnormality was, modeling that in 3 dimensions for what we call source analysis, and then combined it with the fMRI, which is here, where we could see where the function was, well, we could see that the seizure focus seemed to be kind of right behind there. So we did a corticectomy of that patient. It was right behind their motor area and sensory. And this patient has been seizure-free without deficit since we took that out. And tuberous sclerosis is, they have multifocal tubers. But often, if you can identify that they have a single predominant seizure type and it's coming from one area, you may still be able to create seizure freedom if you can target it appropriately. So surgical outcomes, as I mentioned, we've been decreasing the number of large multi-lobe or disconnective procedures or hemispheric procedures. We still do them in the appropriate scenarios. But despite the fact that we're doing that, we're not having worsened outcomes. We're having at least the same amount of seizure freedom and seizure reduction, which means we're preserving more normal tissue. We're taking out less, and we're giving them the opportunity for that better outcome, despite the fact that we're taking out less. They're getting more out of that. So the International League Against Epilepsy created this evaluation protocol as a sort of a practical protocol for evaluation of children with epilepsy in 2014. It's based off of expert opinion and test utilization at multiple centers, but it allows flexibility of the clinical scenario for the patient. And it all starts up here with getting that clinical history, a video EEG, a 3D MRI, and neuropsychology. And I would posit that at the time that they did this, though genetic testing was a thing, it was still quite hard to get, but often I think that genetic testing really should be up here as well, because if you have a normal MRI and you have a very clear pathogenic lesion, you may not want to be going after the pathogenic lesion on the genetics. You may not want to be going after that surgically. But if you have an abnormal MRI and everything's going, that abnormality is still the cause of at least some of the seizures, you may be able to target some of the seizures in that scenario. In the right scenario, you might find that all this comes together and you don't need any additional testing, and you can just go down to 1 stage, 2 stage, doing some more mapping. But there are some times where you need optional or highly recommended testings and sometimes mandatory testing. And that's where we get down to PET scans and SPECT scans, to 3D source or to MEGS, and also to fMRI and WADA. So again, I don't assume everyone is familiar with this, but if you take a look at this one, this is a patient with tuberous sclerosis again, and we have 3 things that are going on here. This patient had seizures that didn't make sense to be coming from the posterior temporal lobe, but that's where they looked like they were coming from on EEG. Of course, they had multiple tubers, so we want to be sure, because they looked like they should have been coming from more frontally based off of the semiology. So we did a SPECT scan in this patient. And in this case, you can see that the SPECT scan, where we are injecting a technetium tracer in as soon as the seizure starts, highlighted that area here in the posterior lateral left temporal lobe. The CT scan also showed a calcification of that tuber. It also showed calcification of a couple other ones, and calcification in tubers often occur in the more epileptogenic tubers. So already we got a couple more going on. And then this is, again, that idea of the source analysis that I had mentioned before. The source analysis is where we take the EEG and we put it into the computer, and we model in 3 dimensions what is the location that best is explaining the source of that current, and what is the orientation of that. You'll notice that it's kind of deep. It's not really where that tuber was. That's actually an artifact of how the EEG is measured. If this was a magnetoencephalogram as opposed to an EEG, it probably would have come up right here along the cortex. And one of the ways to think about an EEG source analysis is like this is a flashlight, and it's kind of pointing out towards the area of cortex involved. And that's why you can see it here, where it's kind of pointing to that area of cortex. This patient had that resection for that tuber that did not seem to make sense for the clinical type of seizure, and those seizures went away. And they were seizure-free for a couple of years. They've developed seizures from a different location now, so we're trying to deal with that. But they had a couple of years of seizure freedom because of that. In the past, there's many ways that we do epilepsy surgery. We can do a surgery where we go in, we do some recording in the OR, we have enough data from before, and we take it out, everything's done, and hopefully they're seizure-free, and we follow them over time to confirm that. Or we may be implanting electrodes, all right? And so this is the idea of planning a grid, as well as a few strips that would go down on the brain. Now, in the past, the way that we would then after planning, put that together would be getting a X-ray and overlapping that and basically making a little diagram that kind of looked like this. But now, of course, we can do other things where we can make a diagram that looks like this, again, utilizing the patient's own brain and the actual co-registration of the CT scan. And what I posit to you is that this looks nice, but this is still just a diagram. It's not really truth, okay? The MRI is a mathematical process. The CT getting co-registered is not 100% perfect. And of course, there's shifts in the brain as the CSF came out. So this is not direct truth, but it's a diagram that makes anatomic and physiological sense. And on top of that, we can then do something where we can actually model the EEG directly on that model by connecting the two. And we can utilize those implanted electrodes to directly stimulate and find where is the cortical function that is important. Of course, the whole brain is important, but the area of seizures is not functioning well, and it's causing things to function inappropriately. But with this kind of stimulation, we can find, oh, their motor area is a certain place. We want to save that if we can. If there's overlap there, we are not going to be sacrificing in this patient their motor function. But with this, all this data, we can then make a refined plan for that patient's surgery. This is the idea of utilizing grids in order to record it. Again, grids and strips, because again, this is a little strip and this is a 8x8. And subdural grids allow us to assess the surface of the brain, the gyral surface, but there's a lot of real estate you're not getting there. So that's why there's this idea of stereotactic EEG, where these are long, thin fibers that have electrode contacts on each of them. So this is a 18 contact electrode that is implanted in the brain. This way we can get deeper structures, sulcal surfaces, medial structures, and also if you have concern that there's a very far frontal process, but gosh, maybe it's actually starting from way back in the occipital and just projecting that way, you can't really do a large enough craniotomy to cover that very well. That's a big deal on a patient, versus you can appropriately sample different areas from very disparate regions, but which might be connected by utilizing stereo EEG. You get a trade-off in that we're not going to put in 20, 40, 60 electrodes, right? Each one comes with a certain amount of risk, and you're only sampling small areas, but you're sampling areas that you can't necessarily get otherwise, and that you can now start to understand how they may be connected. And it's done either utilizing a frame or utilizing a robot to help us place under direct visualization the electrodes. The neurosurgeon still does, of course, the placing, but the robot helps us be well aligned into that. So I've been talking about surgery now for a little bit. I've been saying a lot about testings. I've been saying a lot about all these things we can do to patients. There is a cost to that, right? And it is expensive. And when they looked at the cost, it's kind of interesting. These are patients where they underwent a surgery evaluation and were decided to go for surgery or not go for surgery. Basically the time zero of starting is when that decision would have been made, okay? So here in purple, purple is the color for epilepsy. That's why I use a lot of purple. The cost in that first year is very high. Versus the gray is sort of the cost of the medical therapy. And it stays sort of at this level the whole time. After this, the cost was lower for the purple. Now, it kind of came up back again here, but the cost, when successful, was significantly lower after surgery. And the end result of that is the cumulative cost, where early on, for patients with epilepsy surgery, the cost is higher, but over a long enough time course, the cost of medical care without going to surgery overwhelms it. So if these patients could be identified early on, we may be able to save them and society and all that impact on the cost, assuming success. One of the other important things about this, though, they excluded patients who got these small procedures. They excluded patients who got a vagus nerve stimulator. They excluded generalized epilepsies, malignant tumors, inflammatory disorders, patients who ended up getting metabolic and neurodegenerative. These are truly like surgery naive patients. These are really patients who actually may have been candidates for one reason or another. They did not go to surgery. I think that's relevant because it's not comparing apples to oranges. It's not really saying that, well, these patients all had generalized epilepsy, so of course they didn't go to surgery. You can't do anything about them. These patients in blue, we can restart the clock and maybe get them over to here now, where in the long run their care is going to be less expensive in the long run. So this is a case of hippocampal sclerosis. I've mentioned that we are doing smaller and smaller things, and I don't just mean at our hospital, but certainly at our hospital. A lot of times I get questions about whether or not a patient might be a candidate for a laser therapy. I wanted to kind of show what that looks like a little bit. I don't have a picture of the laser itself exactly, but if you take a look at this patient here, over on the far right, far left rather for you, this is the hippocampus that is bright and small and scarred. That is hippocampal sclerosis, all right? The laser is at the very end of this fiber that has been entered in here. It's placed in the OR, and it's about a centimeter long, and there's a long cooling catheter where we run some fluid in there in order to try and prevent it from getting too hot, but it has to get to a certain temperature. After they get that catheter and laser implanted in the OR, they're taken down to the MRI, where the MRI becomes a giant thermometer, and I am not joking about that. We literally put safety margins around different areas and say, we don't want this area to get too hot, but we need to be sure this area gets hot enough, and for how long. So it's literally being used like that thermometer. And as a result, they perform an ablation. And they may do about a centimeter and then pull back, and a centimeter and pull back. And you get this sort of long sausage-shaped ablation here. There's two lasers on the market, and one of them has more sort of directional capability. One of them is sort of, like I said, sort of sausage-shaped. We only are utilizing one. This here is a coronal view as opposed to this axial, and looks axial, but it's actually oblique view. And you can see kind of how small that ablation is. And this patient is seizure-free. Now, when you're doing something smaller, there has been some evidence that in the case of hippocampal sclerosis, mesial temporal lobe epilepsy, you may have a lower likelihood of seizure freedom, but still maybe 50–60% with the laser. If that's enough to give you, if you are one who has seizure freedom from that, great, because we didn't take out any of the white matter or any of the other structures, and that leads to actually better neuropsychological outcomes. But if that didn't work, it's possible we just need another laser because the hippocampus is not a straight line, or it's possible we need a bigger procedure, so we may be able to do more in that scenario. So the point is that techniques continue to evolve, and this diagram is based off of some of the techniques that were available in 2014, which laser was getting to be available. But here is a new technique, and it's been utilized more in Europe. We utilized this recently for a number of our patients. It's the idea of radiofrequency ablation from the stereo EEG electrodes. These are the same patient, the same images actually, except the difference is that I'm showing where the electrodes are here and here. This is on the right side of the brain, but it just looks this way. And here I've turned off the appearance of the electrodes, and you can see how close around the electrodes those ablations are. So instead of utilizing a laser, we're transmitting a radio frequency signal to do the same thing, to heat it up. And we can use a temperature probe to know how hot it's getting. And the benefit here is we can do that at the same time that we've implanted them, as opposed to with the laser, if we've done this stereo EEG, usually there's going to be a wait before we can do that, because you need things to heal to try and prevent infections. After we've done this, we can still monitor for another couple of days and see if we need to do more based off of the electrodes we have. So this patient had a reduction in their seizures. They didn't have seizure freedom. This patient, on the other hand, I'm only showing the right-sided electrode, but it was a bilateral implantation. There were more on the other side because left was more concerning. Left ended up being over critical function that we couldn't take out, but right was very important in the seizure network. So we decided to do a very small ablation just across a few contacts. That patient was seizure-free for 35 days, the first time all year that's happened. This is a very recent case. This is another technology, and this is related to what the neuro-oncologist from yesterday had mentioned, where he was talking about focused ultrasound to break down the blood-brain barrier. And that's using a low-frequency focused ultrasound, where it's causing a temporary change in the blood-brain barrier. But this is part of a study in high-frequency focused ultrasound for midline brain lesions that are benign. And this is something that may be utilized for hypothalamic hamartoma. It's under investigation. It's not labeled for that specifically. In this case, it was actually, I believe this case was actually a hypothalamic obesity case, but that ended up getting significantly better because they were hyperphagic before doing it. But it's from the same cohort of patients where we also had patients with gelastic epilepsy. Gelastic epilepsy is an epilepsy where people laugh. They're not happy, they just laugh. Sometimes they scream, which is dyscrastic epilepsy. And along with it, it should be noted, it's not just about the laughing and the screaming, it also comes with an encephalopathy. And it is a surgically treatable form of epilepsy, but the problem is getting there without disrupting the hypothalamus, without actually causing critical damage to areas that are very small and very tight together. And the focused beam ultrasound is a possible way to do that in some cases. And so this publication was from the first few cases in that study of, again, the midline brain lesions, but it's being expanded to include specifically hypothalamic hamartoma cases as we move forward. And that was done at our hospital. People here may know about the vagus nerve stimulator. It goes in the chest. It's approved for focal epilepsy above age 4. It's often used off-label for generalized epilepsy. This is not the vagus nerve stimulator. The vagus nerve stimulator is a very good device. There's 3 devices that we utilize that are implanted for epilepsy: the vagus nerve stimulator, the deep brain stimulator, and the responsive neurostimulator. And I would say that they all have their pros and cons, and they all have benefits, and they all have risks. This is the responsive neurostimulator. The responsive neurostimulator goes implanted in the skull. And remember what I showed about the idea of stereo EEG and about strips. You can record directly in this device through either implanted strips or implanted depth electrodes, or a combination of one of each. And from that, this device actually reads the brain waves from wherever you've implanted those electrodes and stimulates to try and stop seizures as they are occurring. It's approved for patients 18 and up for focal epilepsy in certain scenarios. It's being utilized off-label more and more for generalized epilepsy as well. This is a case that we had where we did a right anterior and posterior frontal parietal cortex, and this patient had a reduction in their seizures of 50 to 74%. They were not using their seizure rescue medication as much, and this is an idea that we can see of how often they're having their seizures because they're downloading this data regularly. There may be some times where they forgot to do it, but you can get ideas about seasonality of epilepsy, seasonality of their seizures from this, and also about how well they're going to respond to medications from this. They have not had a generalized seizure, generalized convulsion since that was implanted. This patient had left anterior and left posterior cingulate implanted, and their seizure frequency dropped by 99%, almost went away. Their severity of seizures is significantly better, and importantly, this device comes with a magnet. Now, the VNS comes with a magnet. They have a seizure. You can swipe it, and it'll try and stop that seizure. Here, the magnet doesn't do that. What it does is it tells it to keep a small snippet of the EEG for us to read. We were able to determine they weren't complaining about seizures. Those were actually medication side effects, and we were probably just spinning our wheels trying to change it. And that's new data that we can get with these devices. This patient had bilateral central median nucleus of the thalamus for their generalized epilepsy, and they had a decrease in seizure frequency by almost 90%. They were no longer going to the ER. It was the first year without an ER visit since diagnosis when that was put in, and they weren't using their rescue medicine nearly as frequently. And then this patient, here I'm showing you, this is the same technology, but what I haven't shown you yet is what the EEG actually looks like. This is what it looks like when we get the EEG from it. We get little 90-second segments, and that can be sometimes a little shorter, a little longer, but it changes how many you can keep. And we can see the seizures going on in here. Unfortunately, their seizure frequency did not change, but the seizure severity was significantly better. They weren't having clusters of seizures, they weren't having prolonged seizures, and also they were recovering from their seizures much faster, meaning they were able to go about their day-to-day, and they were no longer having seizures during sleep, which is an independent risk factor for sudden unexpected death in epilepsy patients. So we may have lowered this patient's long-term risk of one of the scariest complications possible. I say may have. So my call to action. Epilepsy causes a significant burden for these patients in the long term. We know this. The more we let them go on with it, the less their life will be. Right? So we want to do something about it sooner rather than later. We want to be aggressive appropriately. We know that it's expensive to treat it in this way, but we also know that in the long run we can reduce costs in many cases in order to provide them that better life. And we also know that the incidence and risk is different based off of how we define things, but that importantly, kids can have improvement in their long-term outcome from these procedures. That they can have better long-term cognition and psychological outcomes from successful epilepsy surgery. And the earlier age of onset risks their cognition more, and the longer we wait to intervene also risks their cognition more. I can't do anything about the idea that a kid starts having their seizures at 2 years of age versus 15 years of age, but we can do something about the fact that they were waiting 2 years versus 5 years versus 10 years to get the right treatment, be that the identification through genetics or be that the surgical procedure. So early identification of intractable epilepsy should prompt an early referral to an epilepsy specialist. Care for the patient should be tailored and specific. And the cost of genetic testing and surgical care in the long run can reduce the overall cost and improve outcomes for these patients. The surgical approach can have many different measures of success. As I've already shown, there's reasons where it may not just be truly seizure freedom, that we can make these kids' lives better. And I do have to have that discussion with many families when we're talking about neuromodulation, that I'm not necessarily offering you seizure freedom, but that we're talking about trying to make your life better. Fewer seizures means a better life for you if we can make it. And we'd really like that to happen for them. This is our team. It's not our whole team, but it's a lot of our team. We have a new neurosurgeon, Dr. Robert Buckley, who's the new surgical director for the epilepsy program. We have our researchers. We've got our fellows over here. I'm very lucky and fortunate to have been part of this team in both my training almost a decade ago and then coming back to the program 5 years ago. And I feel very honored to have been able to speak to you guys today.